In the meantime, let's move on. I'd like to invite Dr. Antonio Frontera to continue this session with a presentation titled Functional Mapping in Sinus Rhythm. And for once, we have the real thing.
Ladies and gentlemen, dear chairman, good morning. The natural evolution of atrial fibrillation manifests as a progression of longer-lasting and frequent arrhythmia episodes. This is the so-called electrical remodeling. During this, we assist to a shift from a trigger to a substrate-based atrial fibrillation. And somewhere, maybe here, should be the point of no return. Every hour treatment, RF, cryo, PFA, may fail. The challenge, therefore, is to intercept the beginning of electrical remodeling. But what's electrical remodeling? We attempt a description of electrical remodeling with this research study published last year on JACI-P. We try to picture in a frame the progression of atrial fibrillation. Here you see an analysis performed during sinus rhythm of slow conduction corridors, the blue lines, in patients with paroxysmal and persistent atrial fibrillation. And we assist, as you see, to an increase in number and density of corridors of slow conduction. And in persistent AFib, these are thicker and they create nests. We also analyze pivot. The pivot is an old-fashioned EP phenomenon that seems every electrophysiologist have forgotten. This is an EP phenomenon that has been described first by the LSC group. This is a paper dated 2002. And in this work, you see the wavefront propagating around the line of block with a pivot of 180 degrees. In the next panel, they deliver an extra steam, and you see what happens after turning point. You have a crowding of isochronal, and this is a slow conduction, which is functional. And if high density is ensured, pivot side can also be displayed in our electroanatomical maps. Here you have an example. So in our research study, we exported our maps of patients suffering from atrial fibrillation by analyzed during sinus rhythm, and we performed an automatic analysis with MATLAB, and we discovered that the number of pivot increased when going to persistent AFib. But the most important finding of their research was to discover this EP phenomena in most of the cases were invisible when we switched to the bipolar map. You see here pivot and light slow conduction corridors with no match with the bipolar voltage. So we may stop to consider bipolar voltage as a complete indicator and informative indicator of normal conduction. And we also did another thing. Next step was to import this data, true data coming from sinus rhythm, into supercomputer to run a numerical simulation of atrial fibrillation. You see here the numerical simulation of sustained atrial fibrillation from data coming from a persistent AFib, and you see here you can spot the left inferior point vein at the atrium, rotor, driver's domain, not sure how to call, let's call it reactivity. And during sinus rhythm, at this spot, we had a thicker area of slow conduction with a pivot associated. And this happened often. So this evidence is not coming only from numerical simulation, but also from ECGI and imaging. This is an elegant work from the Bordeaux group, Hubert Kocher, first author, and you see that ECGI showed the overlaying of phase singularities with Lego-Delinear enhanced distribution, which represent area of fibrosis. So if we wait until structural abnormalities become relevant, the remodeling will be almost irreversible. So the challenge is to anticipate and design a treatment that targets other EP phenomena that sustain atrial fibrillation. So what are the other mechanisms? Everyone agrees that in paroxysmal atrial fibrillation, this is generated by a trigger inside the PV. But what if the PV triggers other EP phenomena in the left atrium? If we build a graph where we plot rate versus conduction velocities, we will not be surprised to have atrial fibrillation at the top right of the graph. Atrial fibrillation has the faster rate and conduction velocities. BT and AT indeed play with lower rate and average conduction velocities. This means one thing, that atrial fibrillation is prone to a functional phenomena. But what's functional? It's something dynamic, which depends on several factors: the rhythm, the rate, the directionality of the wavefront, the anisotropy to the fiber orientation. The key in our lab at Humanitas Research Hospital is, we believe, to link the sinus rhythm with AF activity. And from VT, we'll learn that sinus rhythm is very important. And this is the manuscript, the research study I'm very proud of, most proud of, has been published on Harvard in 2020. And the paper is about the outer loop, but we discovered something very interesting. So here you see first patient, the outer loop, the entrance, the protected isthmus, 2 lines of lock, the exit, and we correlate the activation map at the same site with the sinus rhythm. So we knew exactly what was going on during sinus rhythm. And you see, during sinus rhythm, here you have a line of block, just one. The second line of block is therefore functional. It does not exist during sinus rhythm. And this functional line of block exists because of the rate and the direction of the wavefront. And this VT exists because of the functional line of block. And the functional line of block exists because of the VT. So this is magic. This is lovely. How beautiful is cardiac electrophysiology? And look at this. It's another patient. You see, during sinus rhythm, you have 2 lines of block, but look what happens during VT. The 2 lines of block prolong, and this prolongation are 2 functional lines of block. So we said, why don't we explore this functional phenomena in atrial fibrillation? So we involved other centers, and we choose Cato for several reasons: for the Octray, for the excellent mapping feature of the parallel mapping, I think everyone knows. So basically, you can build with the same time 2 maps, one during sinus rhythm and one during exostem. You see here, we have a free sinus beat and then an exostem. And the exostem was delivered by the distal coronary sinus with a couple interval of +40 of the local refractory period. So we had chance to have, during the same mapping time, 2 maps during sinus and during pacing. So let's have a look together at some phenomena. This is a structural phenomena. This is a sinus rhythm, a map coming from Greece. Thank you, Dr. Stelios says. You see there is a Bachmann slow conduction here and area of delayed activity here. And look what happens during pacing. The same area is displayed. So, and also bipolar voltage, the respective bipolar voltage during sinus rhythm and during pace confirm there is an area of disease here. This is indeed the functional phenomena. So we are on the posterior wall, common left trunk, right inferior pulmonary vein, and here at this side, you can tell there is an area of slow conduction here and an area of delayed activity. And during pacing, there is nothing here, you see? And also bipolar voltage doesn't show any disease. Most of you would say, why don't you do 2 maps? One during sinus and then another one during pacing. Well, the reason is because I like EGMs, I love EGMs. And I like to assess in every site what happens. So this research protocol allows me to assess in every site when I map what happens. And you see here, we are doing sinus rhythm, and everyone agrees with me, I think. This short duration, high amplitude, absence of fractionation. So here, the wavefront is propagating very fast. And during the exostem, here you see there is the same behavior. So this is normal conduction. When I move from this side to another side, you see EGM look pretty similar to the previous one, but look what happens here. This is an S-type response, as I call it in my lab. So basically, the wavefront is trying to turn around something, so it's a pivot site. And when you see now I'm moving to another place, you can tell by the sinus rhythm at the end of the P wave, maybe we are at the posterior wall. And here you have a double potential with an isoelectric line of 33 milliseconds. And when I deliver an exastin shorted by only 20 milliseconds, here you see there is a 61 milliseconds isoelectric line. So it's a functional line of block, in my opinion. And structural and functional phenomena coexist in most of our paroxysmal and persistent atrial fibrillation. You see here the wavefront arrives at this point. There's a heavy slow conduction, two pivot side extremities, and also the bipolar voltage shows there is a disease here. But look what happens during pacing. So we are pacing from the crying sinus. Here you see the wavefront is activating caudocranially the left atrium, arrives at that point. Here there is another slow conduction. The one that we saw during sinus is confirmed. So there are two now, a slow conduction, one confirmed during sinus rhythm, and the second, and also the one during sinus rhythm that was seen by crying sinus spacing. And you see that the bipolar voltage, here there is no disease. So this is a functional line of block, slow conduction, and this is a structural one. And this was very interesting because at that area of delayed activity, I saw this tiny little potential, something like late potential, and I asked my technician to pace from here, and just one beat induced atrial fibrillation. I'm sorry about this one. It was hit by mistake in the keyboard, but you can tell atrial fibrillation starts here. So the main findings are 185 conduction abnormalities seen in almost 40 maps. Mainly these were functional, 44 were structural, and most of them were slow conduction corridors. And during pacing only functional phenomena, these increase the number of pivot and line of block, which makes sense because you are stressing the tissue. Where can you find this functional phenomena? Most of them on the anterior wall, followed by the posterior and also the antrum of the pulmonary veins. And when you look at the voltage, most of them were above 0.5 milliseconds during sinus rhythm. You see here an activation map for the posterior wall. Here there is a line, I would say a real line of block, and a pivot site here, and the bipolar voltage doesn't show anything. And also the functional phenomena during pacing are always above normal voltage, so above 0.5. You see here there is a C-shaped slow conduction area, and bipolar voltage normal. And last but not least, the relationship with anatomy. Here you see an activation map during sinus rhythm. First area of pivot slow conduction here, second one here. So a lot of, I would say a patch activation here. And when you overlay the CT scan, here you have the aorta. But also with the esophagus. You see here, we have an activation map of the posterior wall, and there's an area of delayed activity here. It looks like, I would say, a tube, you see? There's a sort of, you draw something like a tube, and when you overlay the CT scan, there is the esophagus here. And this is another case, another patient. You see activation during sinus rhythm, normal bipolar voltage, and here an area of abnormal conduction. So in conclusion, in patients with atrial fibrillation, abnormal conduction area exists and can be displayed with high density mapping during sinus rhythm. All your comparative analysis of pace and sinus rhythm can highlight the structural function nature of this abnormal conduction. Aortic root and esophagus may play an important role in the genesis of area of abnormal conduction, and we should go, I think, beyond PVI and low voltage areas to identify ablation targets that prevent AF progression, or the so-called electrical remodeling. Thanks to the whole team, and especially to Politecnico Milano of Stefano Pagani. Thank you.
Thank you very much, Dr. Frontera. Please join us on the podium while we listen to the rest of our colleagues, and then finally for the panel discussion. Thank you very much.